In calcaneal fractures, I will be shown a radiograph showing a calcaneal fracture, and I will explain what type of ankle the fracture is. I will describe the fracture lines and involvement of a subtalar joint, as well as quote on the varus deformity or a lateral wall blowout. I will manage the patient as per ATLS guidelines, looking for other injuries, especially L1 fracture, open fractures, or other side fractures. I will admit the patient, make him non-weight bearing, apply RICE. RICE is rest, elevation, compression. I will not splint the patient. I will take a pertinent history from the patient. Regarding patient history, I want to know the level of activity, the risk factors, history of peripheral vascular disease, smoking, diabetes mellitus, and any fixed above or worker compensation. On examination, I want to check the soft tissue envelope of the patient lower limb, check the neurovascular status, exclude compartmental syndrome, and check if it's amenable for surgery, especially like late wrinkly sign. Radiograph which are done is AP, lateral, and Harris axial view, and a CT scan. Harris axial view gives a varus alignment and tell me about the lateral blowout and disruption of subtalar joint. The lateral view will tell me the subtalar joint disruption, shortening, and tell me about the angle of Gazan and angle of Bowler. A CT scan would help me to identify and classify it as per the Sanders classification. The calcaneal has three facets: anterior, middle, and posterior facet. The posterior facet is the most important as is weight-bearing surface area and just below the testicular tali. Angle of Gazan normally is 120 to 40 degrees and is collapsed if the posterior facet is collapsed. The Bowler angle is reduced in calcaneal fracture, but normally it is 20 to 40 degree, and reduction means is collapse. Testiculum tali is like a shell for the talus, and it's the medial part of the calcaneus, and FHL runs beneath it. This is a very important fragment as it's called constant fragment. So normally a calcaneal fracture happens in two planes in a predictable manner, which is the fracture planes goes from anteromedial to posterolateral, creating anteromedial fragment and a posterolateral fragment. These are basically called primary fracture lines. There is a second fracture line which either acts posteriorly, causing a tongue-type fracture, or move superiorly, which is called depression type. And this is the Essex-Lopresti classification. A CT scan is done to classify the patient, the fracture in Saunders classification. In that, I want to have a mid-coronal plane images to classify it. Type 1 is undisplaced, type 2 is displaced when there are two parts, type 3 is there is three fracture lines, and type 4 are 4 and more. There are different configurations with respect to Sanders classification, and the higher the grade, the smaller the constant fragment, and the worse the results. My management decision will depend on patient factors and fracture factors. Regarding the patient factor, I want to know the worker compensation, peripheral vascular disease, smoking, diabetes, and soft tissue envelope. These points, if they are not good, the patient is going away from surgery. Regarding the fracture factors, I need to check for comminution, joint subluxation or disruption, especially subtalar joint, varus malalignment, impingement of peroneal tendons, and lateral wall blowout. These five factors, if they are present, this goes towards surgical intervention. My goal will be having a plantigrade foot, which is painless, and avoiding the risk of arthritis and deformity. A tongue type fracture, if it's a calcaneal tuberosity, can be percutaneously fixed. Otherwise, open intervention is indicated. The open incision is indicated is a lateral approach by Roger Atkins. Lateral approach is uh, the patient is properly marked and consented. Floppy lateral, lazy lateral position is I believe to do in lazy position, lazy lateral position. Skin flaps are created. The incision is pointing mark on the lateral malleus Achilles tendon and the fifth metatarsal. The flaps are thick flaps, and a KY is utilized at the level of the lateral malleus and talus, and I bend them. The lateral wall is blown out, so I will push off and then use my McDonald's to pull it up and create the medial fracture and elevate the articular surface. Then after, I will do a bone grafting and will pack it and then reconstruct the lateral wall and fix with the buttress plate. Regarding the research, Sanders in 1993 showed that it is a complex fracture and should be done by a specialist foot surgeon. Higher the volume of surgical intervention, the better the results. So volume equates the outcomes. Roger Atkins suggested that even if it goes to arthritis, they should be fixed, which means that later fusion is easier to restore the anatomy. A study by Buckley in 2002. This is a Canadian study which showed 424 cases which were managed conservatively as well as surgically, and there was found no difference between the two groups, and subgroup analysis did show that some of the patient factors did worse with surgery and some did better. And they also advocated surgery for some certain fracture patterns. The bias was that in Buckley's paper, the radiological results were assessed by himself. In 2014, BMJ published UK HEAL trial was done. Had a stringent exclusion criteria. It was a multi-center study with 27 surgeons and 22 centers. 150 patients were recruited. They get rid of center type 3 and 4, which needed the surgery at first instance. So they were left with type 1 center and type 2 centers. 150 patients were recruited. They found no difference between surgery or conservative management, but actually more infection and soft tissue injuries in a surgical group. So they concluded that there is no justification to operate on fractures. The study was optimal, but had a conclusion which was a more controversial sort of a result in the foot and ankle community, and multiple outcome results and were discussed and showed heterogeneity in the paper. So at the end, regarding surgery of calcaneal fractures, it's a controversial subject. Whenever I see a patient, I will decide operative intervention with respect to patient fracture and the fracture factors. Regarding the patient factors, I want to consider the soft tissue envelope, previous history of activities, peripheral vascular disease, smoking. Regarding the fracture factors, I want to assess the degree of comminution, involvement of subtalar joint, varus malunion, impingement of peroneal tendons, and lateral wall blowout, and decide accordingly.